Okay, well, it's nice to see all of you, and I'd like us to get started. So I'll begin by welcoming everyone to the Vasculitis Foundation's webinar today. I'm Kathy Olewski, the host for the Vasculitis Foundation Educational Webinar Series, and I'm also a patient living with MPA vasculitis. Today's webinar topic is an overview of Polyarteritis nodosa, also known as PAN, which is much easier to say. And now that all the housekeeping is done, let me begin by introducing our guest for today. We have Dr. Kathy McKinnon, who's an associate professor of medicine and the director of the Vasculitis Center at the Medical University of South Carolina in Charleston, South Carolina. Dr. McKinnon is board certified in internal medicine and rheumatology. Welcome, Dr. McKinnon. We're so happy to have you here with us to educate us about PAN and answer some questions for our viewers today.
I'm delighted to be here. Thank you for having me.
Well, it is great to see you. And honestly, today, I think we're going to give everybody a pop quiz before Dr. McKinnon starts teaching us a few things. So if you'll give me a second to share my screen here, I will get us started on that. All right. You should be seeing my screen any second. Let me move a few things out of the way. All right, and this is your pop quiz for the day today. Let's see if I can get us started here. Polyarteritis nodosa, PAN, is a systemic necrotizing vasculitis first described by Adolf, I think I said this right, Kussmaul and Rudolf Meyer in what year? And the answer is 1866. I would not have gotten that one right. And the next one is, the term nodosa refers to inflammatory nodules, skin lesions, or insomnia. And the answer is inflammatory nodules. What type of arteries does PAN affect? Large-sized arteries, medium arteries, small and medium-sized arteries? And the answer is small and medium-sized arteries. True or false? PAN is more common in males than females. Let's see how many of you get this right. True. It's more common in males than females. And PAN can occur at any age. However, it's more likely to affect individuals who are between the ages of 18 to 45, 70 to 90, or 50 to 65. And the answer is 50 to 65 years old. Which of the following organs does PAN typically not affect? The pulmonary system, the GI system, the sinuses, or the lungs? And the answer is lungs. And PAN can be related to hepatitis A, hepatitis B, hepatitis C, or hep B and C. And the answer is hepatitis B and C. And finally, PAN can affect just the skin. Is that true or false? Well, that's true. And Dr. McKinnon, that was our last of our pop quiz, and I did want to ask you about this one. Does this mean it's cutaneous PAN? Is that what it's called, CPAN? Is that right?
That's correct.
Okay. And we are done with the pop quiz, and I'm hoping that we were able to get Dr. McKinnon's presentation. And if so, we're putting it up right now. There we go.
Aha.
And we'll need it in slideshow version. There you go. And Dr. McKinnon, if you would like to start whenever you're ready.
All right.
Is that in the view that you're comfortable with?
I can see it just fine. As long as everybody else has a good view of it, I think we're good to go. Well, I would like to welcome everyone who is here for our webinar on PAN. It's my pleasure to be here and share some of the things I've learned about PAN over the years. And I've tried to focus a lot of what we talk about patients that I've gotten who've asked these questions as I've seen them in the office. I've been taking care of this disease and other forms of vasculitis now for over 20 years. And I hope that some of the information we put together tonight will be helpful to you. So I have a couple disclosures regarding this talk. One is I'm a primary investigator for an upcoming study, and we'll talk a little bit about some of the treatments later on. And as we often do with vasculitis, we do talk about off-label use of medications, meaning that we use drugs that are not approved by the FDA for the diseases we treat, but with rare diseases, that's more common than not. So the objectives tonight are to talk a little bit about vasculitis. I never know exactly who's in my audience till afterwards, but I realize oftentimes there are people who are new to this disease and new to the diagnosis. And vasculitis is a foreign term to many of us who have never seen it or had it before. So I'd just like to start with that. Talk a little bit about the history of PAN, talk a little bit about the clinical aspects of disease, relate some common questions that I've been asked in the clinic about PAN more than once, and then make some time for discussion and questions from the audience. Next slide, please. So vasculitis refers to inflammation of the blood vessels. And if you remember back many, many years ago to junior high or high school biology, they talk about the arteries and the veins and how these are all interconnected in the circulatory system in the body. Most types of vasculitis affect the arteries the blood vessels seen on the right that have different composition. They have muscular layers, they have an outer layer, an inner layer. And these are all very important functionally in delivering not just oxygen, but also nutrition through the body. So damage to these blood vessels can be catastrophic. So when we talk about vasculitis, itis refers to inflammation. And you can see in the upper part of the slide what a blood vessel should look like. It's a nice round tube. It has a nice wide opening inside the tube, and things that flow to the tube include your cells, white blood cells, red blood cells, platelets, plasma, other things that help in delivery of oxygen and nutrients to the body. And when you have vasculitis or inflammation in the blood vessel, the inflammatory cells go into the vessel wall. They release inflammatory cytokines and chemokines, these chemicals that your body normally uses to fight infection and fight off invaders, now are targeting your own blood vessels. And these vessels over time can become damaged. They can become leaky. They can become fibrotic, where scar forms from this inflammation. And they can form aneurysms, which is actually widening or outpouching of the blood vessels that's not normal. And so the slide just kind of outlines what the consequences are of having vasculitis. At the top, you see a normal artery where things flow very nicely through this uninterrupted opening. And when you have inflammation, like if you have inflammation or a cut on your skin, when things heal over time, there can be scarring, and scarring inside the artery causes this opening to become narrower, making it more difficult for the things that your body needs to flow through there. Less oxygen, less nutrition, which can damage tissues and organs. Going down to the bottom half of the slide, if the artery becomes totally blocked, that can be catastrophic for the area that's supplied by these blood vessels, and that's how strokes or heart attacks can happen. And then aneurysms, which are very common in PAN, are outpouchings of the blood vessels where the wall becomes weakened and starts to balloon out, and these areas can rupture and cause bleeding, which could also be catastrophic. So the quiz and the quiz and the lecture were unrelated, believe it or not. I saw the quiz questions and I thought that it was very interesting that they touched on all the points we would talk about. So you heard a little bit about the history of PAN, but Virchow, who was a pathologist who did a lot of different things in the development of medicine, actually proposed the presence of vasculitis in blood vessels back in 1847. And then shortly thereafter, there was a pathology case that was published describing these aneurysms in the mesenteric arteries being the ones that supply the gastrointestinal tract. And we know about the first description of PAN now, and a quotation from their description of this is intermittent nodular appearance affecting arteries throughout the body, sparing large vessels like the aorta, small vessels like you might see in the skin, and pulmonary vessels, as was alluded to in the quiz, that the lungs are rarely affected by PAN. And a string of pearls is how it was described initially. And you can see on the left, there's your typical string of pearls. And this is beating of the renal artery that's circled there. that represents that. And this is commonly what we do see when we're looking at angiograms or MRI studies of PAN. So over time, this has become more and more of a recognized disease. You can see in the 1930s, there were about 150 reported cases worldwide and 20 in the United States. But over time, as we've used imaging studies more, pathology studies more, we've been able not only to recognize the different forms of vasculitis, but differentiate them into different groups. Initially, vasculitis was all clumped together as inflammatory diseases of the blood vessels despite size. But over time, like in the 1950s, they recognized hypersensitivity or allergic vasculitis. Cutaneous PAN was recognized in 1974, not that long ago, and within my lifetime, and certainly I'm sure other people on the call. It was associated with chronic viral infections like hepatitis in the 1970s. And it wasn't until 1980 that it was clearly separated from ink-associated vasculitis, being recognized as its own entity. And this is a diagram illustrating the more common forms of vasculitis. And you can see where PAN fits. I've highlighted it there. And although it's listed as a medium vessel vasculitis, our diseases don't oftentimes read the rules or the textbooks and can overlap. So sometimes we see patients who have larger vessel disease, sometimes they have smaller vessel disease, but the predominant artery that's involved in PAN is the medium size artery. So one of the first questions that patients often ask me is what causes PAN, and we really don't know what the cause is. We believe that patients have a genetic predisposition to vasculitis. Like other autoimmune diseases, we oftentimes see autoimmune disease run within families. Not necessarily the same disease, not necessarily the same type of disease, but autoimmunity in general. And there are some mutations genetically that I'll touch on a little bit later that are associated with the PAN-like disease. We think that there's some alteration in the normal immune system. Toxins or chemical exposures in the environment may change the immune system and predispose to PAN. We know that hepatitis and HIV have both been associated with PAN. And what we think happens is there's something associated with these triggers, with the toxins, with the viruses, where the immune system is turned on, but the body's not able to turn it back off again like it normally would. Your immune system normally becomes more active in the setting of infections and inflammation. And when the threat to the body is down, the immune system turns itself back down nicely. But in the cases of autoimmune diseases and vasculitis in particular, this immune attack against the blood vessels continues. And so in a nutshell, we think that this stimulus to the body, and in this case, the virus, influences other immune cells and identifies the body's tissues as a target. And for some reason, the immune cells that normally look at you and recognize the different parts of your body as self don't recognize it, hence the attack against your own tissues. So next, we'll talk about some features of PAN. And it's important to remember that not all patients have all features. If you see these slides up here and you have PAN, it doesn't mean you're going to have all of these things. This just kind of describes the spectrum of what this disease can do. So general signs and symptoms. And although this looks like me in the morning most days, this is very, very common. And oftentimes one of the earlier manifestations is just fatigue that's way out of proportion to the amount of sleep you've had, the amount of things that you've had to do, the stress in your life, just this disabling fatigue that keeps you from doing a lot of the normal activities that you enjoy. Patients can have fevers without any infections, fevers that persist for days or weeks. Body aches are very common, muscle aches, joint pains. Patients oftentimes from this ongoing inflammation can have significant weight loss. And one of the features of PAN, and even listed in the classification criteria, is the development of new high blood pressure in someone who's never had issues with blood pressure before. This slide represents a skin condition called livedo reticularis. And you can see it has this lacy appearance of this redness of the legs. This can come and go. This can become more prominent under stress, or if you're cold, this can be very visible. And if you're warm and relaxed, sometimes this can go away. This is not just seen in PAN as a precautionary note. We can see this oftentimes in young women who are healthy, women with other autoimmune diseases. So the presence of this does not mean that you have PAN, but it's a very, very frequent skin condition that we do see. We can also see Raynaud's phenomenon on PAN, which means that when your hand or your fingers or toes become cold or under stress, they can turn white, and it's a very intense blanching white. The flip side of this is sometimes when the blood vessels are affected and become very narrowed, or they become completely occluded. You can actually have complete interruption of blood supply to the finger and develop gangrene of the finger or toe. Cutaneous PAN, as was alluded to in the quiz before, is inflammation and vasculitis that's isolated to the skin. This can cause ulcerations of the skin, and oftentimes non-healing ulcers are an indication someone may have PAN, or nodular lesions that are tender, bumps that you can feel below the skin, also that can persist for weeks or months without treatment. And if you think about how your body is wired with the circulatory system and the blood vessels that run throughout, it's not surprising that PAN can affect many different areas of the body, can affect the brain, the heart, the gut, the kidneys, and the nerves. And as we mentioned before, typically does not involve. And these two pictures are representations of an artery that's cut cross-sectionally. And looking at the picture in the upper left, you see this ring of muscular layer, and in the middle of it, you see all these tiny red dots that are blood cells. Those are circulating through your body to do their job, getting blood and nutrients where they need to go. On the bottom right, this shows an artery that has been affected by PAN, and that nice ring is not so nice anymore. It's kind of broken, and instead of those nice blood cells in the middle, you see all this tissue and inflammatory cells, which is obstructing blood and nutrients from getting to the areas of your body that they should be in. And this is an angiogram looking at the kidney. And you can see in the picture on the left, this is a very nice straight artery where the line points. And you can see rather straight looking branches going out into the kidney itself. The angiogram on the right shows a kidney of a patient who has PAN, and you can see what look like bubbles or circles in the arteries. And these are aneurysms that have developed from inflammation in the arteries of the kidney. This can affect the brain as well. And this shows angiographic studies of arteries that are going to the brain. The left side of the brain, the back of the brain, and the vertebral arteries run up the back side of the brain as well. And instead of seeing those nice straight tubes, you see rather ragged, beaded looking arteries. And looking at those, you can understand why people have problems with their brain and circulation and even stroke from this disease. A neuropathy is a common manifestation of PAN, and sometimes it's the first manifestation of disease that we see. And you can see different terms. And if you read about PAN on the internet or printouts that you have from your physician, they may talk about neuropathy. And mononeuropathy describes involvement of one nerve. So it may be numbness of an arm or loss of function of a hand. Polyneuropathy often is affecting smaller nerve fibers, and you can be seen in many places on the body, most commonly in the hands and feet, becoming numb and tingly. And mononeuritis is when nerves are directly involved, larger nerves, where you can lose function, and it can be a wrist drop or a foot drop. And in some patients who are unlucky, it can be in more than one place at one time. And as the quiz touched on, there are different types of PAN. Cutaneous is considered a subset of PAN. It is limited to the skin only. And in most patients who have this, it's rare to progress to systemic PAN. And we talk about systemic, meaning that the whole body can be involved. It's typically internal organ involvement, one or more places, but it also can involve the skin as well. And making a diagnosis of PAN can be a long and arduous journey, as many of you who have this disease may have found out yourselves. It's oftentimes not something that's diagnosed on the first or second visit, but sometimes it's the third visit. It's the hospitalization after months of illness. There are clear classification criteria for PAN, but those are typically used for research studies to make sure that you're getting patients into studies that have the disease and have similar features of the disease. PAN in the clinic and at home and in the community is much more tricky than that. And it might present just with some fevers and joint pain, maybe presents with just high blood pressure. And really what happens is somebody who sees you has to put these pieces together to recognize PAN, which is frustrating, as many patients are sick for a period of months before they're diagnosed. So some of the key aspects of diagnosis. This so frequently involves the internal arteries that abdominal vascular imaging, things like a CT angiogram or an MRA study, are used to look at the abdomen and the blood vessels in the abdomen in patients who are suspected to have PAN, who have abdominal symptoms. Sometimes imaging for other causes, just imaging, a screening imaging or imaging for abdominal pain will reveal these changes, which may be an early key to the diagnosis of PAN. Oftentimes, patients have peripheral manifestations. It's very hard to go in and take a biopsy of an artery, but it's much easier to take a biopsy of the skin or the nerve if that's involved in this particular case. And blood tests, which we often use for other autoimmune diseases like rheumatoid or lupus, which can be very helpful, are more often than not negative or non-diagnostic in patients with PAN. They may have low positive autoantibodies or non-specific autoantibodies, but typically they're not the key to making the diagnosis, with the exception of evaluations for chronic viral infections like hepatitis or HIV. If those are present, that also can point in the direction of PAN in the right setting. And looking at blood counts in general, because of the inflammation in the body, patients can have elevated white blood cell counts, platelet counts, anemia, all things that go along with chronic inflammation. Unfortunately, they're rather nonspecific by themselves, but can point in the direction of this diagnosis. More recently, scientists have been looking at genetic links to this disease, genetics being one way of looking at treating diseases more permanently in the future. And they found in the pediatric population primarily this deficiency of adenosine deaminase. It's an enzyme that aids in the development and differentiation of different immune cells, so immune cells being tied into autoimmune disease. And if you look at the features, very similar to some of the features we talked about earlier on: fever, ulcers of the skin, livedo-reticularis, strokes, neuropathy. And typically these patients present, because it's a genetic disease, in early childhood, but there have some rare cases described in adults, and it's treated differently. It's triaged to using a specific class of drug, anti-TNF therapy, earlier, and patients with this particular mutation do better with this treatment. So kids who present with signs or symptoms suggestive of PAN are now being routinely tested for this. And as we look deeper and deeper into the genome of human disease, we found other conditions that are associated with PAN-like disease. And these have interesting long names: stimulator interferon genes associated vasculopathy, interferon genes being associated with inflammation and immune activation, and vasculopathy just describing abnormal condition of the blood vessels, the Candle syndrome, and there have even been some post-COVID and COVID-associated syndromes that are associated with vasculitis and vasculopathy in some cases that look very much like PAN. So in summary, diagnosing PAN can be very much like the old story about the blind people evaluating the elephant, depending on what happens first. The trunk is a snake, no, maybe it's not, the tail is a rope. And I don't think I could have said it better than one of my new patients that I saw on Monday. And she said, "Doctor, I've seen a doctor for this, a doctor for that. I'm tired of seeing doctors for different pieces. Can just one person put the pieces together and figure out what I have?" And I think that really is the key in making this diagnosis and identifying PAN. Next slide, please. And we know that PAN is a chronic disease in many, and probably most patients that I see with it, it is a chronic disease, like high blood pressure, like diabetes, a disease that you keep with you lifelong, but it is treatable and manageable. The 5-year survival rates with treatment were reported around 80%. That was primarily when we had a lot of hepatitis-associated diseases. And back before we had treatments for chronic hepatitis, there were a lot of other reasons that people would not do well with this disease. But now that this is less frequently arising with hepatitis, and even in the patients who have this with hepatitis, chronic hepatitis can often be treated. So I would say that survival rates overall, this is probably a low estimate and are better for most people. We know that relapses can occur with vasculitis in general, and this disease is no exception. Almost half of patients will relapse over a 5-year time period. Oftentimes, this is much more prevalent if there's no treatment. Maintenance therapy oftentimes can help cut down the risk of relapses. And patients who have very localized disease sometimes can be cured by surgery. Typically, those patients don't make it to my clinic, but end up seeing a surgeon or someone else along the way. So people in the rheumatology clinic tend to have a more chronic form of PAN in general. So treating PAN is art more than a science. And as I alluded to at the beginning, the rare diseases rarely have very many FDA-approved drugs for their treatment. So we borrow drugs from other conditions, other subspecialties, chemotherapeutic drugs primarily. And most people get steroids at the beginning. Steroids control inflammation very quickly. Controlling inflammation is the key to controlling damage, minimizing scarring, protecting organs and tissues. We still use cyclophosphamide or Cytoxan for severe disease, but as we're using more newer immunosuppressants, hopefully, like with other forms of vasculitis, this will become less commonly used, and we'll be using some of the newer drugs that have lower long-term risks and side effects, like methotrexate, azathioprine, IVIG, mycophenolate, and even some of the newer drugs, biologic therapies, have been used successfully in the treatment of PAN, and of course, in patients who have viral infections like hepatitis or HIV, antiviral treatment is a very important part of their treatment regimen. And as you know, any of you who have taken steroids, just from steroids alone, there are many potential side effects. Most people get at least one, if not more than one. We worry about infections in people on these medications because their immune system is lower to treat the disease. They're also more susceptible to infectious complications of disease. Steroids can cause bone loss and osteoporosis. Steroids can predispose you to developing diabetes or high blood pressure. Weight gain, very common if you have to take high doses of steroids for a long time. And that's just a short list of the side effects of steroids, which is one reason we're always looking for newer and better treatments for this disease. But there is hope, and there are things to do to help prevent some of these steroid side effects. We typically use calcium and vitamin D to help prevent bone loss in people who are taking steroids for longer than just a few weeks. We try to minimize the amount of steroids that people get by using some of these other medications that I mentioned. In special cases, we do use antibiotics to help prevent certain infections we know that are more commonly occurring in people whose immune systems are lower. We do our best to vaccinate everybody against preventable diseases, and we encourage good self-care, getting adequate rest, healthy diet, stress management. All those things can be helpful. And I've listed just a few questions that have come up over the years more than once in patients who are newly diagnosed. Maybe some of you out there had some of these questions or had entertained them at some point. Hopefully they'll be helpful. Next. So because of the association of hepatitis and HIV, and oftentimes people being told this is an immune disease, they ask if it's an infectious disease. Can they transmit it to their family? Can they transmit it to anybody else that they're around? And even though this can be associated with an infection, PAN is not infectious itself, and you can transmit it to the people around you. Next. And oftentimes people will come into my clinic and say, well, I've been working too much, I've been stressed, I don't eat well, did I cause this disease? Did I do this to myself? And I try to make a point of saying that this is just a problem with the immune system that you did not create, that you did not cause, that people are not at fault for getting an autoimmune disease. It's nothing that they brought on themselves. In a lot of ways, it's just bad luck of the draw. Next. And then, of course, the question is, after you've been diagnosed with a disease, is how do we treat it and can we get rid of it? And we don't have a cure for PAN right now, but that hopefully will be down the road. Next. And young patients who have families or are planning families, want to know if their children will get PAN, if they have children, or if they already have kids, are their kids at risk for developing it? Knowing that autoimmune diseases oftentimes run in families. And unlike diseases like lupus and rheumatoid arthritis, where we often see multiple family members affected, this doesn't seem to be the case with PAN. Next. And reading about steroids and side effects and other immunosuppressive medicines like cyclophosphamide or mycophenolate that we use, patients oftentimes ask also if there's a vitamin or natural treatment for PAN. Can you use supplements? Can you use acupuncture or other treatment modalities that are not traditional pharmaceutical medications for PAN? And the answer is no, not by themselves. But I have had patients who have wanted to use additional treatments, complementary therapies or naturopathic therapies, and if they're safe and not immunostimulatory, think they could be a benefit in combination with more traditional treatments for PAN. Next, please. And then the question is, when you have a chronic disease and a chronic illness and you have to take medicines that have potential side effects and risks that are somewhat intimidating, do you have to stay on treatment forever? And the answer is maybe not. There are some people who have had treatment for a period of time who come off their treatment and remain in remission. For other people, that's not true. But this kind of leads into the next section of the talk about things that are coming in the future that I think are very relevant to this question. Next, please. So when I say coming attractions, it doesn't mean necessarily like we're going to get the next Star Wars movie for Christmas, but it's not in a galaxy far, far away either. It's somewhere in between. Things that are just emerging on the horizon for autoimmune diseases that I think will be very applicable to PA in the near future. And I'm going to start talking a little bit about cell-based therapies. Next, please. So there are a number of different ways to approach treating diseases that involve the immune system. And as you can see by the diagram on the slide here, there are stem cell-based therapies. And I'll talk a little bit more about stem cells because that's where a lot of the treatment in autoimmune disease is heading. But I'll also touch on non-stem cell-based therapy using immune cells to correct deficiencies or deficits in the immune system, other non-immune cells to deal with other parts of the body. Chondrocytes affect bone, fibroblasts affect connective tissue. All of these modalities are being looked at to treat problems within the body rather than being a transient treatment like we see with medications where the effects of the treatment stop when you stop the medications. The hope is that changing the composition and the activity of cells within your body can enact a more permanent treatment for these type of diseases. Next slide, please. So you may hear on the news about stem cell therapy, or if you have family members or friends who have been treated for cancers, you may hear about it as well. It is in the works and is being used in other diseases. But stem cells are primitive cells, meaning that they can form other types of cells. They're the beginning of a line of cells, and sometimes they can go in more than one direction depending on what's happening in your body. But you can see that these cells can go to different areas and target different problems in the body, going to muscle, bone, fat, and cartilage, decreasing inflammation, fighting cell death, which also can stimulate autoimmune disease. So there's a very good reason to look at stem cell therapy as part of treatment for autoimmune diseases. And for diseases like scleroderma, for diseases like lupus, there have been some clinical trials of stem cell therapy looking at decreased inflammation, decreased activation of abnormal immune cells, getting rid of the products of cell death, which can increase immune activation, can help blood vessels grow, can help nerve tissue grow for neurologic diseases. So all in all, this is looking to be a promising therapy. We're still very much in the early stages of this. And many of the studies that are being done in autoimmune diseases are putting in just these stem cells by themselves with the hopes that they can detect the need in the body and go to the areas of need and help repair, which seems to be what's happening. But what's thought to be part of the future of this is learning how to treat these cells with different inflammatory chemicals or anti-inflammatory chemicals to already direct them in a certain pathway of inflammation that's in the blood vessel. So when you put in these cells, they're more targeted. They can go directly to the areas where they're needed and enact the change to help regain health and control disease. Next, please. And gene therapy, also something that's pretty much in its infancy, but it's being used for other immune-mediated diseases and other, but particularly more genetic diseases at present. Next. So how does this work? You hear on the news about gene therapy, people getting better, sickle cell disease, one of the diseases that had a lot of attention for gene therapy. So gene therapy addresses something in your body that's defective because of genetic cause. You have a mutated gene, you have a gene that's missing, your body isn't making a protein or substance that it needs. So you get a new gene, the gene that you need, and you put it in a virus that's been inactivated, that can't cause disease. It goes into the cell, it goes into your body, it deposits the gene there into another cell. These cells reproduce, and over time, you have cells that make the gene that you were missing, and the gene that's there helps make the product that your body needs. And there are also more complicated ways of doing it, probably more getting at how this will be used in autoimmune diseases, is where you do find this gene. It is put in a virus, but it's put directly into a cell where it's needed. And then the cells are put into people who need this treatment. It's being done as other types of therapies now, especially in cancer-related diseases, but likely will be the future in autoimmune diseases too. And you can see that this slide lists where these are being used already. So this, to me, I think is very encouraging. This shows that this is the reality of this types of therapy. And it did start primarily in genetic diseases and cancers, but is working its way out into other diseases, particularly those that are immune mediated. So my hope is that sooner rather than later, we'll be entering this realm for patients with vasculitis too. So one of the questions, once people have digested their diagnosis, oftentimes have started on therapy, start thinking about getting off steroids, taking less medicine, they always ask me, what can I do? What can I do to help take care of my PAN, help take care of my body? So we talk about things that seem very general, but are important. Healthy diet. Steroids do bad things to your cholesterol, bad things to your blood pressure. Can be, and healthy diet also is antioxidant, anti-inflammatory, good for you, good for your heart in general, good for your disease. Not getting adequate rest puts additional stress on your body, and as many of you with autoimmune diseases know, that stress is bad for your disease. People oftentimes have more disease activity and more flares when they're under stress. So getting adequate rest, decreasing that stress on the body is important for good health, which also alludes to stress management, which is perhaps even harder than taking medications a lot of the time, but is important in disease management. I think it's very helpful when you have a rare disease, and it can be very lonely to have a disease that you don't know other people who have. But thank goodness for the Vasculitis Foundation, who's helping bring people together to share their experience of their diseases, to have a good support system. And it could be a spouse, it could be a child, it could be a friend, it could be an online network of people, just people that you can talk to, which also helps with stress management. And I think for people who are very early on in their disease, it's very encouraging to talk to people who have already walked their pathway, who have got their disease under control, who are on the other side of this doing well. Medication management sometimes is hard. Insurance companies can make getting treatments hard. Keeping track of all your medications when you don't feel good is hard. Getting a system in place, oftentimes, pill boxes, phone reminders, alarms, things that help you remember to take your medications can be very helpful, especially when you're first getting used to it. Coming to the doctor for regular checkups. Sometimes the blood tests tell us that the disease is starting to become active before you feel sick. So keeping a regular eye on your blood tests and being examined regularly is important for good health. We do put you at risk for infection with the medications we use. And although the vaccines we have are not perfect, oftentimes getting vaccinated against things like flu or pneumonia, instead of the infection putting you in the hospital or the ICU, it can lead to a milder infection that allows you to recover at home and be less sick and less at risk. So we do encourage people to be vaccinated regularly and protect themselves and what we can protect you against. And I think one of the things I can't emphasize enough is making sure that you have a good team that you feel comfortable with. It's very, very hard to go see a doctor who you feel doesn't listen to you, doesn't hear you, doesn't understand your concerns about medication. So for good communication, for good care, it's important to find the doctors that take care of you, that you feel comfortable with, that you feel confident in. So just in summary, I want to leave you with that PAN is a treatable and manageable disease, especially any of you who are listening who are recently diagnosed. It's overwhelming to get a disease you've not heard of, one that can potentially affect your internal organs. You have to take medicines with side effects and risks that concern you. And that's a lot to swallow at the beginning. But keeping in mind down the road is disease remission, less medications, more normality back in your life. Those of you who have this disease know it can be tricky to diagnose and can be diagnosed much, much later than we would like to make the diagnosis. Treatment, we're not as sophisticated as the cancer doctors yet, who do genetic testing and tell you that you need a specific drug for your type of cancer. For PAN, it's more trial and error. We're hoping, and I'm thinking that probably within the next 10 years, we will be at the point that the cancer people are, that we'll be able to do genetic testing and say, yes, you have this particular gene, you have this particular enzyme, this drug should work best for your disease and be much, much more targeted. So hopefully we'll be there soon. And that I also want to remind you that that you're just not hurtling out of control here with this disease. We are monitoring you closely. The blood tests help to keep an eye on what's going on internally. Having to get the scans periodically lets us know what's going on with your arteries. We monitor the medication. Some of them do have drug level monitoring. So we are doing our very best to keep track of everything that's going on and making sure your disease is getting under control as quickly as we can get it there. And just reiterating again, make sure you have a good team, good doctors that you can talk to, who listen to you, that you feel heard when you go to your visits, and you feel comfortable and confident going forward with your treatment. And that is all I have to say tonight. I thank you for your patience with our little technical glitches at the beginning, and may be happy to answer any questions that I can.
Yes, well, thank you, Dr. McKinnon. That was a great overview of PAN, and I hope that we haven't seen any questions be submitted yet, but I do have a question of my own, and I hope people will start to put questions. Remember, look for the Q&A box at the bottom of your screen, and that's where you can put your questions. We would like to have some for Dr. McKinnon, and she'll do her best to answer the questions in general. But since she's not your doctor, she cannot give you any specific advice today. I just ask people to bear that in mind. One of the first questions that I had was, you talked a lot about the disease itself and the disease process. If somebody, and about having a good team, and if a patient is struggling and not sure they have a good team, do you have any advice as to where do they turn first? Do you find a great rheumatologist? Do they need to go towards a medical center? Not everybody is lucky enough to have a vasculitis center in their backyard. So any thoughts on that?
You know, I sometimes get patients who are diagnosed, who seem to be struggling, who I worry that they don't have confidence in the diagnosis. They're worried about the treatment. I oftentimes offer them a second opinion, somebody that I trust. And I encourage people who feel that way to go talk to their doctors and just be honest. Say, listen, this is really hard for me to deal with. There's a lot of information. I'm feeling kind of overwhelmed, feeling a little unsure about what's going on. Do you think it'd be helpful to get other opinions on this? Could I see somebody else to talk a little bit about these medicines, particularly ones that have side effects that are more worrisome? And I've been in the position and I've offered that to patients who have decided to do that. And I've come back and said, they said the same thing. I feel much more comfortable going forward. Let's go ahead with the treatment. And then I've had the other side of it, somebody recently who came from somebody in the community because he has a very rare form of vasculitis. And he was a physician himself. And he said, listen, I think I'm getting good treatment. Just want to double check with you to make sure, because I know this is something that you take care of. And he was getting excellent treatment, and he felt very happy and went back to his doctor. And I think underwent his treatment with more confidence too. So I think that if you have a doctor that you would like to try to keep a relationship, just having that open discussion, being very honest about your feelings, where you're struggling, is a great starting point. And to get to your point about not having access to referral centers, especially in the area I'm in, there's a lot of rural areas where even access to primary care is a problem. So I am working with a group of vasculitis doctors. We actually have our first meeting tomorrow afternoon to talk about ways to get out into the community, be accessible to community rheumatologists and the patients who need us there, whether it's phone a friend or virtual consults or other ways. So we do realize it's a problem, that there's not a lot of us that can be everywhere, but we're trying to figure out how we can be in more places and be more available to you.
Well, what a great effort for the community. We appreciate that you're doing that. We have gotten quite a few questions, so I'll run forward with a few of them. Is cutaneous PAN more rare than systemic, and how is it treated? Similar to systemic PAN, topical medications?
Cutaneous PAN, oftentimes we can use less intensive medications. It is rare that we have to use medicines, the stronger medicines like cyclophosphamide for it. So oftentimes patients can be treated with lower potency medicines that have fewer severe side effects and risks. Not that all of these medicines don't have some potential risks, because they do, but oftentimes we don't need the intensity of therapy the same types of chemotherapeutic drugs to get it in remission. And as an adult rheumatologist, I will say that I see much more systemic PAN than cutaneous PAN. I think my pediatric colleagues would tell you the opposite.
Oh, interesting. Okay. And here's a question about the DADA2. Is it a form of vasculitis or something totally different? And why is it important to find out if a patient has PAN or DAD2?
Well, I think that this is a relatively new discovery, and the thought is this causes a pan-like disease. It causes a lot of the same manifestations, but because of this mutation that they found, that it responds differently to treatment. That there are more targeted therapies for this particular one, which is the reason for testing it and testing for it routinely in kids now. You might not go to medicines like cyclophosphamide for severe diseases, but you could use the anti-tumor necrosis factor drugs instead. And in the pediatric world, they really do try it. Even we don't like cyclophosphamide and use it only when we absolutely need to. In the pediatric world, they're even more. The tendency is even to stay further away from it than they can. So in that respect, this discovery has made treatment better for kids with this disease.
Well, how exciting. We always need new discoveries and new information. Someone says, and this is such a common vasculitis question, are you usually on maintenance medicine forever? I'm still in the treatment stage on cyclophosphamide.
Oh, I would say more often than not, I have people that stay on maintenance medication, but not everyone.
Mhm.
And so the treatment stage of cyclophosphamide is what we consider the induction stage, meaning that you have active disease, and the goal of treatment with this is to put your disease in remission. That is usually anywhere from 3 to 6 months for most people. And then at that point, we switch to a drug that has lower risks, lower toxicities, usually lower side effects, and work on getting you off of prednisone at the same time. Once you're off prednisone, then the thought typically we go 1 to 2 years on maintenance medication, and if everything stays quiet, you stay well, we think about backing down on the dose. And then depending on how catastrophic the disease is, I mean, disease that involves the brain, the heart, the nervous system, I am less likely to suggest a trial off of medication. Patients who have had milder disease, we can at least discuss it. But patients, and I've had some younger patients who have wanted to try to completely taper off medication after that 2-year period off of steroids on maintenance treatment with no flare-ups. But typically, if we're going to try that, we do it slowly, not just going from drug to zero drug, but dropping the dose of the drug over time and checking blood work more often, visits more often, just to see if the disease flares. But we know that in most forms of vasculitis, about half the patients do have relapses. So that's just something we keep in mind. But no, the goal would be to have people on as little medication as possible just to minimize the long-term risks and side effects.
Okay, thank you. And I need to ask you before we go too much further, are you okay if we run a little bit over? We started a little bit late. We've got a few more
Oh,
questions.
sure.
Okay, great. This person, you did answer part of this question already, but I do think in the end of the question, they have something valuable to ask, but well, it's all valuable. But at what point can a doctor try to wean off the immunosuppressants to see if the patient is in remission, and how do you recommend going about it? I think you kind of answered that. Do you decrease the dose every 3 or 6 months? And how often do you recommend blood work while on the medications?
Well, the medications are a bit different. So if you are one of the patients receiving cyclophosphamide at the beginning, you're typically getting blood work every week or every 2 weeks at the least. Once you're more into the maintenance phase, blood work oftentimes I would say is anywhere from every 6 to 12 weeks, depending on how you're doing. As you're tapering the steroids, it's probably more frequent. Once you're off the steroids, just on maintenance medication, oftentimes I go to about every 3 months. With visits about that often as well.
Mhm.
If you've been in remission for a prolonged period of time on your medication and you want to come off, my own personal approach is to start getting blood work every month again. So as we lower the dose, and I would typically lower it every 2 or 3 months, just a small amount. So say if you were on something like 100 milligrams of azathioprine. So maybe we would lower it to 75, check your blood work every month for a few months, then lower it to 50, check your blood work every month for a few months, and continue to see you every 2 to 3 months, just to make sure that we're, if it does start to flare up, we're keeping a close eye on you and your blood work, so we can figure that out early and avoid the disease going into full-blown flare and you becoming very ill.
Well, that sounds like a very reassuring method of how to do it. So that sounds great. The next
I think it
question.
makes
Go ahead.
I think it makes me feel better and the patient feel better. I don't like to wonder what's happening inside their body while we're making adjustments to their medicine. So I have more peace of mind doing it that way too.
That makes so much sense. The next question is, do the nodules that happen with PAN cause permanent damage, scars?
They can. For some people, if the disease is treated early, when it's in the inflammatory phase, things that are just inflammation can get better with treatment. If it progresses to the point of damage to the blood vessels, the skin, or both, that can cause scarring and leave scarring behind.
Okay, and another interesting question, are there other types of vasculitis that PAN is close to, more similar to MPA or GPA? It's an interesting question, because as a MPA patient myself, I definitely saw things that you talked about today that coincide with my MPA. Interesting.
Definitely, definitely. And I think that as that diagram I showed alludes to, that our diseases are not strict about what blood vessels they affect. So I have seen patients with diseases like MPA who have inflammation of the aorta. I've seen patients with PAN who have had inflammation of the small blood vessels in the finger. So I think that because these diseases overlap, we can see overlapping features. Some of the things I think that are common are the constitutional symptoms, the fatigue, the fevers, weight loss, joint pain, muscle pain. I think many forms of vasculitis share that. And the blood vessel involvement, I have seen patients who have small vessel vasculitis. One gentleman who had he had the stomach artery involvement that looked very much like PN. It was surprising, but when we went to look at the literature, there were other cases like him reported. So obviously our diseases don't follow the rules and read the books. And so yeah, there certainly can be overlap.
Interesting. And I'm going to ask you one last question, and then I have some information that I would like to ask you about your vasculitis center. But the question is, how can you tell the difference between atherosclerosis and damage from PAN?
Well, that's a great question.
Hmm.
That's an excellent question. So in looking at the pattern of damage in the blood vessel, sometimes can be very helpful. When you have vasculitis, oftentimes there's damage to long areas of the blood vessel. So rather than an atherosclerosis where you can get plaques that build up, it's oftentimes very patchy, and there are very small areas of narrowing. In vasculitis, it tends to be a longer part of the blood vessel, so you will see longer areas of damage, more of the blood vessel. If you look at it as this tube here, you might see just this little knot of atherosclerotic disease and plaque here. But in a vasculitis patient, it may just extend for a good bit of distance. Another thing that can help us is looking at vascular imaging studies. And probably the best test to help look at this is a PET scan. It's paired with a CT scan. And the PET scan looks at metabolic activity in the tissues. So if there's active inflammation in the blood vessel, you can see the inflammation. Active inflammation high levels of active inflammation relates more to vasculitis than to atherosclerosis. There can be some very low level patchy inflammation in patients who have atherosclerosis. And I think the other thing that confounds the picture is that if you get inflammation in your blood vessels from vasculitis, you are more likely to develop premature atherosclerosis there as well. So oftentimes we're looking at both. We're looking at some scarring and damage, and we're looking at some premature atherosclerosis in younger patients because of the inflammation there. So it's not easy to tell sometimes, but really the question in looking at whether you need treatment or not is there inflammation in that area of artery, or is it quiet? And I think that's where some of these additional tests help.
Well, that was a great explanation. We honestly, we do have probably 10 more questions here, but I don't want to keep you over time today. I'd be interested to know if you would be, some of our webinars, what we do so that we stay sort of on a timeline is we ask the doctor to come back and just do a recorded non-live version where we can ask you these questions and get the answers, and then we'll tag it on the Vasculitis Foundation's YouTube channel where we post this video. Is that something you'd be open to doing?
Oh, sure.
Okay, well, I just want to reassure all of you that we do see your questions and we will try to get the answers for you and get them all added onto this video after the fact. And so we appreciate the questions. They started coming after I said, well, we don't have very many questions. Now there are quite a few. So with that, I did just want to say thank you to you for coming today and spending your time with us and educating us. We certainly appreciate it. Before I wrap up with a little more information for the people watching, is there any final note that anything you want to say?
Well, yeah, I think so. I would like you to know that there are many of us who have made this disease our life's priority in medicine, and that we're spending our time and effort in research for treatments for what causes the disease, how best to treat the disease, how to take care of people, their whole body with the disease. So we are very much here advocating for you. And rare disease or not, this has become our life's work. And we're very grateful for you coming and listening to what I have to say. And I just encourage you all to just form those good relationships with your providers. Don't feel like you are stuck in a relationship that isn't good for you. Don't feel like you have to stay with somebody who's not listening. And it's interesting. I'm working on another project right now with the VPRN, the Patient Powered Network, about what patients want from their doctors. So hopefully I'll be able to say more intelligent things after we do this project. But I see a lot of people who are getting good care for their vasculitis who just feel like that we as physicians aren't doing a good job of explaining things to them. We're not open, we're not responsive. And I think we could do a lot better job of having good relationships with patients. But I think it's important to find that person that clicks with you, that you can trust, that you can talk to. I think the better the communication is, the better care you're going to have for your vasculitis. And as I always tell my patients too, especially the ones who come from that situation, I was like, please call me out if you feel like I'm talking over your head, if you feel like I just wasn't listening today. Before you go find another doctor, just sit down and tell me. This is because all of us have bad days, all of us have busy days. It might have been the day I was up all night with a sick kid and I seemed a little not quite there in the visit that day. But let us know how we can take better care of you too.
Well, excellent advice. And I have to say, you said a lot of very intelligent things already today. So we appreciate that. And I did want to, just say for everybody that's watching today that you have and I don't know the exact timing of it, but I know that there is a new vasculitis center in Charleston, South Carolina that you are leading. And is that just in 2024 that happened? How challenging was that, getting a vasculitis center started?
Well, I'm in a wonderful institution. I have a very supportive division. We have a great infrastructure for rheumatology. Rheumatology is one of the powerhouses at Medical University of South Carolina. That's not true at a lot of medical institutions. Rheumatology is oftentimes the stepchild, but it's been very, very well developed here. So I was recruited specifically to start a center because there are a lot of patients with vasculitis in this area and not a lot of rheumatologists. We're short on rheumatologists to start with, but even more so for vasculitis. So it took about a year to get our research registry up, the center put together, and we are opening 2 treatment studies for vasculitis in the next 6 months with more to come. So it's exciting. It's good to be in a place where you're needed, and I've already identified excellent colleagues in nephrology and in neurology, some of the other specialties we work very closely with. So very happy to be in South Carolina now.
Well, as a vasculitis patient, we're very happy to have another vasculitis center opened. And, particularly for me on the East Coast, I always think that's very important. It's important everywhere. Can patients that are viewing this video later or watching today, can they reach out to your office to be seen as a patient? Do they need a referral from their doctor? How do they do that?
I, I'd be absolutely happy to see anybody, even if it's just for second opinion or just, just discussion about their treatment or what's happening with their disease. I have a vasculitis triage system, so anybody who's referred to the institution or calls for an appointment who has the diagnosis, that comes directly to me within 24 hours, just to make sure that I can get people who are sick or who have more urgent needs in quickly. So if you feel like you need help that's more immediate, need some advice quickly, that's something I can do.
Gosh, that's outstanding. I love hearing that you've developed that system, and because it's one of the most common things we hear at conferences is how long it takes to get to see somebody when they're so sick, how hard it is. Well, thank you so much. You mentioned the VPPRN, so I am actually just going to talk about it for just a second here before we finish up today. And you should be able to see my screen right now. The VPPRN is the Vasculitis Patient Powered Network, and I'm actually a patient champion for the VPPRN. I encourage other patients to join the VPPRN and to complete their biannual forms. And I can't tell you everything that you need to know about VPPRN, so I encourage you to learn by visiting their website, which, as you see, is vpprn.org. What I can tell you is that it's a global patient registry. Patient data, that means your patient data, drives the research in vasculitis. Dr. McKinnon talked about a lot of the up and coming research. Our data is what drives that research. So by providing researchers information about you and your experience, that's actually the key for advancing our knowledge of vasculitis. So I love to talk, especially because you mentioned it, I love to talk about the vasculitis, the VPPRN, and hope patients get involved in that. And I also wanted to say that we need to say thank you to our sponsors, Amgen, AstraZeneca, and Novartis, and of course, the Vasculitis Foundation for supporting these medical webinars and making them possible. And Dr. McKinnon, thank you so much for your time today and also for your promise to help us with the rest of these questions in the future.
Absolutely. My pleasure.
All right. Thank you, everybody.